We're going to go through the high yield points of what to do if you're seeing a patient that has what looks like orbital fat prolapse. It sounds harmless, and most of the times it is. But like many things in medicine, there are other diagnoses that you want to keep in mind, and one that might surprise you. New to the channel, welcome. I'm Dr. Alana Jasper-Trotter. I'm a board-certified ophthalmologist. If we take a step back, what even is the purpose of orbital fat? It actually has many beneficial purposes that helps to support the eye and surrounding structures within the orbit. The orbit is a bony socket that contains many structures like muscles, nerves, blood vessels, lacrimal gland, and the orbital fat. It cushions the eye, protecting it from injury, and also helps to prevent the eye from hitting the bony socket. It also provides structural support to the nerves and blood vessels that support the eye. It cushions the extraocular muscles so they move easier. It also provides volume. And you may have seen, in patients as they age or in trauma situations, there can be fat atrophy, and that can lead to the sunken eye appearance when there's less fat within the orbit. Orbital fat prolapse is a benign condition where fat that's naturally in the orbit moves anteriorly to a different position, and commonly this is the subconjunctival space. And that occurs due to weakness in a support structure called Tenon's capsule. So most commonly, the weakness occurs due to aging, surgery, or trauma. It's a thin fibrous membrane that encapsulates the eye, separating it from the orbital fat. Tenon's capsule fuses with the sclera 5 millimeters posterior to the corneoscleral junction. And this is really helpful when you're seeing a patient on exam and you're trying to figure out what this is. So when looking at the eye, if you notice a hard stop, and a space of clearing where you can see the white part of the eye, the sclera, that's a good clue on exam that what you're seeing is orbital fat prolapse. That doesn't mean that this isn't orbital fat prolapse. What you can do is put a numbing drop on the eye like tetracaine or proparacaine. And of course, if you have no concern for an open globe, have the patient look in the opposite direction and get a Q-tip and very gently see if you can push that yellow tissue away, because maybe the way that it's prolapsed so much has come forward, especially in a trauma. It may appear that it's abutting the limbus, but if you gently roll that yellow tissue away, it may reveal a space of clearing. Let's talk about symptoms. Most of the times, it doesn't cause any symptoms, and this could even be an incidental finding that when a patient opens their eye, you have them look in the opposite direction, it brings that fat prolapse more into view. They may not even know that it was there. Occasionally, and this isn't common, that a patient would have symptoms, but some symptoms that they could experience would include irritation, tearing, or double vision. It can be bilateral or unilateral, and the classic location is let's try that again. Don't ask me what happened. On exam, what you're going to see is a soft, yellowish, mobile tissue in the temporal location that's in the subconjunctival space, and it has fine blood vessels anterior to it. Risk factors include age. So again, the support structure like the Tenon's capsule is getting weaker, trauma, surgery, thyroid eye disease, and obesity. What do you do in a trauma situation? Well, taking a step back, either the fat was already there or the trauma may have led or worsened the orbital fat prolapse. Clues that the fat prolapse was due to the trauma. Asymmetry. Let's say you have a patient who fell and hit the left side of their face, and the fat prolapse is either only evident on the left side or it's much more noticeable on the left side compared to the right. Also, maybe the patient wasn't aware and they're like, I've never had this before. With the patient's permission, if family's at bedside, you can also ask them, is this something that you've noticed before or has it been present for some time? And also, if they have any pictures that shows the patient's face that maybe you could take a look at to see, to help, determine the onset, if this is truly new or is it something that's been there for some time. You may not know the origin or the onset, but in these acute settings, the key is what to do. And that's what we're going to talk about next. So I'm going to break this down into two parts. And the first is to confirm that it's fat clinically as best as you can. Assuming there's no concern for an open globe, put a numbing drop on the eye like tetracaine or proparacaine. You can also put a drop on a sterile Q-tip and have the patient look in the opposite direction from where the orbital fat is. And with that sterile Q-tip that's moistened, gently touch the fat. So the fat should be soft and mobile, and it has blood vessels on top of it. And now you're pretty sure that what you're seeing on exam is orbital fat prolapse. Part B is to rule out orbital compartment syndrome, which can be a vision-threatening diagnosis. And we'll talk a little bit about that later on in the video. The 5 key things to do to rule this out: checking visual acuity, pupils, intraocular pressure, confrontation visual fields, and motility. Checking visual acuity, you want to make sure that the vision is at or close to baseline. And be sure to check out the video that I did about how to check visual acuity and go more in depth about that. Is it at baseline or is it far from baseline? Is the patient losing vision? Pupils. Of course, in any trauma setting, wanting to double check that the pupils are equal, round, reactive, they're not tear-shaped or irregularly shaped, which could be concerning for an open globe. But especially in this situation, you want to rule out a relative afferent pupillary defect, because that could be a strong clue that there's an issue with the optic nerve. For example, orbital compartment syndrome. Pressure. Now, this is going to be really helpful when you're trying to rule out orbital compartment syndrome. When I receive a consult and whoever's consulting me is concerned about orbital compartment syndrome, if they tell me that the pressure is within normal and it's been checked multiple times, I'm not as concerned because the pressure is normal. So what is suffocating the optic nerve in this case? But if I'm called and they're telling me the pressure is 42, 40, etc., I'm concerned. So taking a step back, what's considered to be normal for intraocular pressure is 10 to 21. So in this context, we have orbital fat prolapse in a trauma setting. You want to make sure that it's not elevated. Now, if it is elevated, make sure you put that numbing drop on the eye. But also recheck it. Tell the patient to breathe, to relax. If the patient's really tense, if they're holding their breath, that can falsely elevate the pressure. Fourth thing to check is peripheral vision by checking confrontation visual fields. So this is important because it gives another data point, more information about the potential of the optic nerve status. The patient has a visual field deficit, especially if it's on the side where there's the orbital fat prolapse, the pressure's elevated, and they have a relative afferent pupillary defect. Well, that's very concerning, and it's giving more data that, hey, something acute here is happening. Number 5 is motility, so checking the movement of both eyes. So basically what you want to rule out is a motility deficit. If the patient can't move the eye in a certain direction, or if the eye looks frozen and it can't move in any direction, that's definitely concerning. If all 5 of these are within normal and the patient's asymptomatic, then have the patient follow up outpatient with ophthalmology. Important diagnoses that you don't want to miss in an acute setting include a tumor or foreign body, which these often have a different clinical or radiological appearance. Especially in a trauma setting, what you don't want to miss is compressive optic neuropathy, and that's also called orbital compartment syndrome. In rare situations, the orbital fat, instead of moving anteriorly, could actually move posteriorly and compress the optic nerve. And similar to a heart attack, time in this case is vision. So if the optic nerve is being suffocated, you only have so much time until that can lead to permanent vision loss and even blindness. Another situation is a patient who has orbital emphysema, and that's where there's an accumulation of air in the eyelid or the orbit, commonly due to trauma, especially orbital fractures. In a situation where the fatty tissue is disrupted or damaged, if there's also air in the area, and how am I going to demonstrate this? Let's say this is air, here's the orbital fat tissue. If it gets trapped and the air can't find an exit, the air could also back up, and that could also contribute to or lead to orbital compartment syndrome. Luckily, orbital compartment syndrome is not common. And if you've otherwise blessed the eye, there's not concern for an open globe or anything. Compressive optic neuropathy is one of the main things to keep in mind when you're seeing orbital fat prolapse in a trauma setting. So orbital fat prolapse, compressive optic neuropathy, they both have 3 words. Just rule it out and hopefully you'll be able to sleep at night. If you'd like me to do a video on orbital compartment syndrome, go ahead and leave a comment down below. You may be wondering if you should get imaging. Orbital fat prolapse is a clinical diagnosis, so seeing it on its own does not equate to getting imaging. When you could consider getting imaging is if what you're seeing on exam, it's kind of leading you to pause and it's something may seem off. You need to get more information. Also, if you're worried about a tumor or foreign body, or if you're seeing a patient who sustained facial trauma that warrants imaging, depending on the type of trauma that the patient sustained, they may have already had the imaging done. And if so, you could use the imaging to help confirm whether this is orbital fat prolapse or something else like the lacrimal gland. On a CT, the fat's going to appear hypodense. So if the fat is coming from the intraconal space, it's almost going to look like a continuous river that's moving anteriorly and then it's bulging forward. As a side note, if you have enough concern for orbital compartment syndrome, don't wait for imaging, don't wait for ophthalmology to come in. That's one of the handful of ophthalmology true emergencies, and you need to act now. All right, so let's go ahead and talk about management. So as mentioned, most of the cases are benign. I know we spent a lot of time talking about compressive optic neuropathy because it's a really important no misdiagnosis, but luckily it is rare. If the patient is symptomatic or they're bothered by the fat prolapse aesthetically and there's no urgent concerns, you can have the patient use preservative-free artificial tear eye drops 2 to 4 times a day as needed, and have them follow up with ophthalmology so they can see if they're a candidate for surgical excision. Regardless of the situation, assuming there's no urgent concerns, I would recommend that the patient follow up outpatient with ophthalmology because this can help to confirm the diagnosis, rule out a need for a biopsy, as well as ensure stability. And I'm going to end with this. It can be really difficult to see things on exam, to be consulted on a patient, to have a patient walk through your doors and not know what you're looking at. Trust and believe, I know, I've experienced it, and it can be overwhelming. Remember the clinical context, consider the age, common things are common. We know about them zebras, but common things are common, and maintain a differential diagnosis and never be afraid to ask for help. I hope this video was helpful. If it was, let me know in the comment section, as well as if there's certain topics that you're hoping to see on the channel. Let's make today a good day. All you can do is your best. I'll see you in the next video.